All right, so this week we're going to start looking at the venous anatomy. So this is just again like a little introduction into the central and peripheral venous system and the anatomy of the vessels. So we discussed first the central venous anatomy. So this is the inferior vena cava, the IVC, and its tributaries. Then we'll focus on to the peripheral venous anatomy, and then a little bit of the microscopic anatomy of the vessel walls, comparing again the arterial and venous vessel walls. So for us in vascular, we primarily image the inferior vena cava. The superior vena cava is very, very difficult to see if we're actually able to see it at all on patients, just because it's so central. It's obscured by the lungs. Those of you that are in cardiac will be able to visualize the SVC, but if you're not doing an echocardiogram, typically the SVC is not imaged, so we're focused more on that IVC. So this is the main pathway to bring blood flow back up to the heart. This is that main river where all the other small tributaries drain into. The main tributaries that we're going to focus on for the IVC are the hepatic veins, the renal veins, and then the common iliac veins. So all these vessels converge together and drain into the IVC. So just working your way from superior to inferior, you have your hepatic veins, draining blood flow from the liver. So again, we have right hepatic vein, middle hepatic vein, and left hepatic vein, draining the various corresponding segments or sections of the liver. We have the renal veins, one on each side, right renal vein, left renal vein. And then we also have two common iliac vessels, right and left common iliac vessels that drain into the IVC. So again, normal IVC anatomy, this is the major venous drainage. The common iliacs come together around the level of L5 of the spine. The IVC lies anterior to the spine. So if the patient's lying supine, we'll see the IVC and then the spine behind it. It lies to the right of the aorta. So patient's right, it's on the right side of the body. Terminates in the right atrium. Again, as common with all veins, the IVC has thinner walls and lower pressure when compared to the aorta. It's easily visualized in the upper abdomen using the liver as an acoustic window. So when you guys start getting into scanning abdominal ultrasound, you're going to utilize that liver, and you should be able to see that IVC coursing posterior to the liver. So the liver sits in front of it. The liver is very vascular. We can use that as the nice acoustic window to be able to see the IVC. So this is now a sagittal image of the IVC. So it's either longitudinal or sagittal. Remember, we can use those two terms interchangeable. So we can see the IVC coursing across our screen. So this is our notch. This is the patient's head. That way is the patient's feet. So here's a section of the patient's liver. And this is just showing how we can use that liver as a nice acoustic window to be able to visualize the IVC. So the patient's diaphragm is here. So above here, the patient's heart should be sitting. Depending on how thin that patient is, you can actually see the heart kind of beating on the opposite side of that diagram.
So the arrow is pointing to the diaphragm?
Yeah, the arrow is pointing to the diaphragm. Yep.
Where is the knot on the photo?
So the patient's notch is always represented by this side of the ultrasound screen. So like I know that, I see the IVC as elongated as opposed to a circle. So I know my transducer, we'll use the chalk box, is going to be in a sagittal orientation as opposed to transverse, slicing that. I know my IVC runs up and down. So when I see my vessel as elongated like that, I know that I'm in a sagittal orientation. My notch is always going to be pointing towards the patient's head. Has Jen done any of that with the Play-Doh yet? Or did you start now with the Play-Doh? I think that might be this week. So you guys are going to get into slicing things, sagittal, transverse, and then the probe orientations. So. With this, I kind of adjusted it a little bit with inspiration, expiration, IBC changes in sizes. So again, just kind of remember the blood flow with the inspiration and expiration. With you know what? Scratch this slide actually completely. Erase this slide. I want you guys to just be familiar with inspiration and expiration as it relates to blood flow in the extremities. With the IVC, it's a little bit tricky because it can vary slightly whether you're taking deep inspiration or shallow expiration. Just know with the Valsalva maneuver, that's going to cause your IVC to bulge or dilate because you're creating a cessation of blood flow. And you're increasing that pressure, so you're impeding blood flow from going to the heart. So that's going to cause that vessel to dilate. So this is something that we utilize quite often when we want to image the IVC, is we'll try and have them Valsalva to see if there's diameter measurements or differences in diameter with the IVC with the Valsalva maneuver.
So should we just leave that?
Yeah, just recognize that when you Valsalva, it's going to cause your IVC to bulge or dilate.
Not the deep breath, but then you then get into-
Yes, yeah, so it's a deep breath in. Don't let any air out of your nose or mouth and bear down to try and tighten up your stomach muscles. So last week we talked a little bit about pulsatility in the arteries, monophasic, biphasic, triphasic, the different arterial phases of waveforms or descriptors that we use. In the venous system, we don't have that biphasic, monophasic, triphasic. We just refer to the phasicity of the wave of the venous waveform as it relates to our breathing, our respiration. So in the venous system, we would just refer to the waveforms as being either phasic or continuous. Yes. Waveform. Descriptions. So one of the descriptors that we use is this term phasicity. So a venous waveform, it either demonstrates. So we're going to say it either demonstrates phasicity, meaning it follows respiration patterns. Or it's continuous. So with continuous, it doesn't follow respiration patterns. We're gonna pause this. Oh, wow, sensitivity and specificity. So we say a waveform is phasic when it follows our inspiration or our expiration. So we get a waveform that kind of looks like little waves. So if it's, if we're looking at the lower extremity, we said when the patient takes a deep breath in, we get less flow. So this would be our inspiration. And expiration. When they breathe out, we get, increased flow. So it's, if this were, we were imaging in the lower extremities, when they're breathing in and out, they breathe out, we get an increase in flow. When they breathe in, it's less out in. So we could actually see their respiration patterns on our waveform. So phasic follows the patient's respiration patterns. We get those nice little waves. So this is normal. We would expect this. So phasicity or phasic waveforms are normal. Normal venous flow pattern. So this is the other, or the opposite of this would be that continuous flow pattern. So continuous. You get a waveform that's close to the baseline and basically just pretty much flat, where you don't get much respiratory variation at all. It's just kind of just a continuous, like, not following the patient's breathing. So, continuous wave or continuous venous waveform pattern. There's little or no respiratory variation. So this can be considered abnormal. When we get into the venous next semester, we're going to learn about some of the different conditions that could potentially cause this. So the most critical thing is this could potentially indicate a blockage or obstruction. So we think a blood clot or a DVT somewhere in the body that's stopping that blood flow from getting back to the lungs. So we have this phasicity because there's nothing impeding that blood flow from getting to the lungs. So we just got the blood flow in that IVC being able to circulate, make it back to that right atrium. So we have the influence of our breathing and our heart in these waveforms. There's one more waveform called a pulsatile waveform. So I'm going to go back to here that we could use to describe venous waveforms. And this is something that we see when we have vessels that are close to the heart. So when we're listening to a vessel that's close to the heart, the waveforms can take a more pulsatile feature to it. And this is because we're getting influence of that heart. So this is contraction of the right atrium that we're picking up some of the contraction of that right atrium and some blood flow being ejected either backwards. We're picking up cardiac pulsations from that heart in our venous waveform. And this is referred to as pulsatility or pulsatile waveform. So pulsatile waveforms, we see that in vessels that are close proximity to the patient's heart. Pulsatile venous waveforms. So it looks really choppy. It's kind of hard to see, that real inspiration, expiration, and a nice continuous, phasic waveform. This one's more choppy. It's got the pulsatilities from our heart being picked up in those waveforms. So pulsatile venous waveforms, but normally seen. And vessels close to heart. There we go. So this is left arm, so vessels that are close to the heart, we could think of internal jugular vein, innominate vein, maybe the proximal segment of subclavian vein. That's on the left side. So do we have a nice right side? So here we go. So now you can see the heart. So for sure SVC if you're able to see it. But again, IVC, innominate vein, maybe proximal subclavian vein, innominate vein on the left side, IJ, proximal subclavian. So any of these vessels that are fairly close to the heart, you're going to have those pulsatile waveforms. So that's a normal finding to have a pulsatile waveform in veins that are close to the heart. In fact, you want to see pulsatility in those vein forms. So that's normal. That's good. Yep.
So the first time I read the thing, the doctor was looking at,
Jugular vein.
yeah, and we could see the pulsing, is that what you're seeing?
Yes, so normally the veins will have a nice, these are some more examples of pulsatile veins. So you're seeing some pulsatility to it where it's not just nice rounded rolling waves. Those nice rounded rolling waves are more indicative of let's see if I got those on here, of extremity vessels that are further away from the body.
Yeah, I think that like when we got to the jugular, we can see it pulsing on the ultrasound.
Pulsating, yeah, I mean the artery for sure you'll see it, in the vein, yes, yeah, the vein should pulsate a little bit too. So again, so this is normal. We expect to see pulsatility in those vessels that are close to the heart. If we lose pulsatility and we have something that's more continuous and flat, not a good sign. So that could indicate the potential for, some sort of central thrombus or some sort of blood clot blocking, that blood flow from getting to that right atrium. We've lost the influence of the lungs and the heart at that point because something is blocking it. So this is just another diagram showing aorta IVC in relation to each other. So hepatic veins. There we go. So we have three tributaries. There's a right, middle, and left hepatic vein. Each of those drain into the inferior vena cava. So to go back to those two terms, hepatopedal and hepatofugal. So pedal, we said, was coming towards the liver, so blood flow entering into the liver. And then fugal, hepatofugal, meaning blood flow that's draining out of the liver, away from the liver. So in this case, normal hepatic vein flow should be away from the liver. The hepatic veins, again, have a very telltale or unique Doppler signal, where they have an antegrade systole and diastole, as well as a segment of it that's retrograde that creates this W-shaped waveform. So there's a brief moment where you get some flow reversal when the atria actually are contracting and pushing back a little bit of blood during that atrial contraction phase of the cardiac cycle. So this is now a transverse view on the liver showing the hepatic veins. So transverse is the best way for us to visualize the hepatic veins on ultrasound. So notches towards the patient's right. So you're getting a little bit of the right hepatic vein here, but you can see clearly the middle and the left. So this is that funny sign that you guys are going to become familiar getting. And then turning in sagittal, here you can see the IVC and then the right hepatic vein joining into the IVC in the sagittal view. And this is a normal hepatic Doppler waveform. So that area that's above the baseline is showing blood flow going in the opposite direction. This is during that atrial contraction where you get a little bit of blood reversing backwards. And then you get that nice kind of W waveforms. This is normal hepatic artery Doppler waveforms. So these look very unique. So renal veins, renal anatomy. So the veins lie anterior to the arteries. So if the patient's lying on supine on their back, when we're imaging them with ultrasound, we should see the veins sitting on top of the artery. So the artery should be posterior to the vein. So vein on top, artery behind it, posterior to it. The right renal vein is shorter than the left renal vein and extends directly to the IVC. So IVC is on the patient right renal vein or right kidneys on the patient right. So just thinking of it logically, that right renal vein should be much shorter compared to that left renal vein, because that left renal vein's got to go from the left kidney, cross over midline and get to the IVC, which sits on the patient's right. Left renal vein, so has a unique orientation. So normally in most patients, it of course is anterior to the aorta, so in front of the aorta, but posterior to the SMA. So here's that superior mesenteric artery coming off that anterior abdominal aorta wall. And that renal vein kind of sandwiches in between the two of them. So of course it's in between the two. The reason that's important is later we're going to learn that there's a couple of conditions, something called nutcracker syndrome, where patients can actually have compression of that left renal vein by the aorta and the SMA. And if we compress that vessel, we can wind up with blood clot or thrombosis within that left renal vein and affect the kidney and cause problems with kidney function. Another slight difference too between the left and the right renal veins is the left renal vein, the left gonadal vein actually connects to the left renal vein, whereas on the right side, that right gonadal vein connects directly into the IVC. There's some theories that because of that, we can wind up with thrombosis in this left renal vein a lot easier than we can on the right side, which could lead to issues with either the ovaries or the testicles. When you get into doing testicular ultrasounds, you'll tend to see that patients have more varicoceles or dilated veins on the left in the left testicle or surrounding that left testicle. Maybe because the pressures or the resistance is higher in that left gonadal vein because it's connecting to the left renal vein as opposed to directly into that IVC. So you can have some anatomical variations. So in this case, we said normally that left renal vein, of course, is anterior to the aorta, so it should be in front of it. Here we're seeing a retro-aortic left renal vein. So IVC and transverse, aorta and transverse, and that left renal vein going from the left kidney. Now it's coursing posterior behind the aorta into that IVC. So that's an abnormal anatomical variant. Then this was kind of that same picture now with the color on. So here's our inferior vena cava aorta. And you can see that left renal vein coursing posterior or behind the aorta when it should be anterior to it. So the same way we had the renal artery tributaries, we have the corresponding renal vein tributaries. So everything now is just kind of working in reverse. So we start with the small interlobular veins. So those are in the cortex of the kidney. So that outer layer of the kidney is the cortex. Those drain into these arcuate veins. The arcuate veins are the ones that surround these little pyramids. So these little areas that kind of look like kernels or little candy corn kind of. Those are the filtration or the pyramids of the kidneys. And the arcuate veins sit on top of those little pyramids within the kidneys. The arcuate veins then drain into the interlobar, which then drain into the segmental, and all that converges into our main middle vein, which then exits and drains blood out of the kidney. So, peripheral venous anatomy. So when we're talking about the venous system, we have to recognize that there are several different types of veins when we're talking about our peripheral venous system. We have deep veins, superficial veins, and then perforators or connecting veins, which connect the deep system to the superficial system or superficial veins. So deep veins, they're inside the muscular fascia. They're almost always duplicated, meaning there's two veins to each artery. And the big characteristic for deep veins is they're always accompanied by an artery of a corresponding vein. So for instance, if we're looking at the upper extremities, we have subclavian artery. That artery is going to be corresponded with the subclavian vein. So that since there's an artery of the same name, it's a deep vein. If we move down to brachials, we have a brachial artery. Brachial artery in the arm. We also have brachial veins. So those brachial veins are considered deep veins because there's a corresponding artery of the same name. If you're talking about upper extremity now, we also have the cephalic vein in that upper extremity. This one's considered a superficial vein because there's no cephalic artery. There's no artery of a corresponding name. So when you actually image it on ultrasound, the deep veins are going to be running right next to their corresponding artery. So kind of think of it as a 2-lane highway. Deep veins will always have a corresponding artery adjacent to it of the same name. And that's basically how you can differentiate deep veins from superficial veins when you're imaging in the extremities. If there's no artery with that vein running adjacent to it, then it's a superficial vein. The perforators, so these is the connection, these veins are the connection between the superficial and the deep system. Blood flow in the perforator veins goes from the superficial veins into the deep veins. So this is important when we get into venous, knowing this flow direction, because when you have reversal of that flow direction, that's when you wind up with varicose veins or varicosities. The other thing we're going to talk about is the valves that exist within these peripheral veins. The valves are bicuspid, meaning there's 2 leaflets to these veins, and they have what's called a valve sinus. So that's the actual insertion site where the valves attach to the veins. The number of valves will increase as you go from proximal to distal. So the more distal you go in the veins, the further away from that heart, the more number or the higher number of valves you're going to encounter. So vessels that are much further away from the heart are going to have a much higher number of valves or a larger number of valves than vessels that are more central or closer to the heart. So this is the patient's skin, and we're looking kind of inward at the patient. So this is more superficial skin surface. This is deeper within the muscular fascia. You can see the deep veins and superficial veins coursing through, and then the perforator connecting the superficial veins to those deep veins. So blood flow. This looks like it's going to be a lower extremity. So blood flow is going up the leg. Blood flow is coursing up the leg in both the superficial and the deep veins, but we do get some crossing over of that blood flow, the superficial veins into that deep system as well. So blood flow comes up the legs. Some of it gets diverted into that deep system, some of it continues going up in those superficial veins as well. So in terms of perforators, so when we focus on these perforators, we're looking at the lower extremities. Trying to think the mnemonic that some of the other students came up with. So they remembered hippies don't bite cheese. That's the one that they came up with. Kind of working their way down, Hunter, Dodd, Boyd, and Cockett. So the hunters are going to be in this around mid-thigh. This is the hunter perforators or hunter and perforators. The Dodd's perforators are going to be in that distal thigh, so still above the knee. Around the level of the knee is when you have the Boyd's perforators. And then in the calf, you have the Cockett or the posterior tibial perforators. So they remembered it, hippies don't bite cheese. As they work their way down the leg. Who came up with that? I think it was Rochelle. Again, these perforators connect the superficial veins to the deep veins. So this is a little schematic showing how the venous valves are constructed. So they're bicuspid, meaning there's two leaflets. So these are the two leaflets of the valve that swing open and shut. They have a valve sinus. So this is a part of the vein where it starts to bulge or dilate, and it's the insertion site where those valves are attached to. Within this valve sinus, you do have the potential for the development of clot or thrombus. Because when this valve swings shut and prevents blood flow from going back, you have little pockets where you could wind up with some pooling or collecting of blood that can eventually congeal or form into blood clots. So it's important to check these areas where you do see dilatation of the vessels where these valve sinuses are, to compress in that area to make sure that there is no thrombus located in these areas. So in the lower extremities, these valves open with expiration when we take that, when we breathe out. Then that diaphragm's coming up, so now we have lower pressure in that abdominal cavity. So this should promote venous flow in that lower extremities. So with that, it forces those valves to open and we get forward flow through the calf muscle. With inspiration, those valves close. So this is now we're going back to the upper extremities here. So we're going to focus first on the deep veins of the upper extremity. So internal jugular vein. So it's one on each side, right and left. So I'm just going to do the right arm. So internal jugular vein, it's courses along the lateral side of the common carotid and internal carotid arteries. So we said this was pretty close to the heart, so it should have a pulsatile waveform that's seen here, so that's normal. So these are all deep veins, so you can list these all as deep veins. These are all going to be deep. We'll make it blue. It's our IJ. Internal jugular vein. The next vein that we typically image on ultrasound is gonna be our subclavian vein. So that IJ drains into the innominate, which goes down to the heart. And the subclavian vein also drains into that innominate vessel. So subclavian vein courses along the anterior chest, so it's posterior, it's posterior to medial end of the clavicle. It's posterior and inferior to that artery, so it's below the level of that artery as well. IJ, so it's gonna be our subclavian. This guy is the innominate. So subclavian vein is still fairly close in proximity to that heart. So here's on the left patient's left side now. So again, you have your jugular vein, internal jugular vein, subclavian vein, they both come together to form the innominate. So this is sternum midline. So that left innominate vein is eventually going to cross over midline to the patient's right side. So that's this guy here. This is now, so this was right innominate, left innominate. It's coming across. And it's gonna join the right innominate and form the SVC, so that SVC then goes into the right atrium of the heart. So if we continue working our way out, subclavian vein eventually becomes the axillary vein, so similar to arterial flow. And then that axillary vein then is formed, so you kind of have to think of everything as in reverse now. So it's small little streams coming together to form larger rivers. So that axillary is formed by the coming together of the basilic vein and the brachial veins. So axillary, we had coming across the anterior chest. I'm sorry, subclavian, we had coming across the anterior chest. Then we get into the axillary, the patient's axilla. The axillary veins. So subclavian becomes the axillary at the border of that first rib. So when we're measuring or imaging the axillary, we have two, well, when we get into venous, there are two windows that we can come from, either anterior or actually going in the patient's axilla. Again, axillary has a corresponding artery that's with it as well, because it's a deep vein. Once we get into the upper arm, we then have the brachial veins. So this is upper arm, we have our two brachial veins. So axillary crosses the border of the teres major muscle and becomes the brachial veins. This is in the upper arm. Axillary. Brachials. So one thing to notice is once you get down past the axillary, the deep veins now become paired. So you see two veins. So the brachials are going to have two veins. The radial and ulnar are also deep veins because there's corresponding arteries of the same name. And they're paired as well. So you'll have two radial veins and two ulnar veins. Radial veins are going to be along the thumb aspect of the hand. Or lateral. You get down in there, and then the radial along that medial aspect of the hand. So again, just remember anatomical position with your palms forward. Ulnar is gonna be along the medial aspect of your arm, radial along the lateral aspect. These are all deep veins. The reason it's important to differentiate between deep veins and superficial veins is because it changes your medical diagnosis. So if you have a blood clot in the deep veins, that's a DVT. So that's important because the DVTs typically require anticoagulation. These deep veins really have a direct connection back to the heart and lungs. Superficial veins, if you have clot in those, that's a completely different medical diagnosis. That's called thrombophlebitis. And with thrombophlebitis, typically they don't anticoagulate. They don't put those people on medications. They just maybe might prescribe warm compresses, will leave some of the swelling and the pain, and the body will just break down those clots on their own. The superficial veins, depending on where it is, don't have a direct connection back to that heart or to the lungs. They have to enter into the deep system first before they can get back to the heart and to the lungs, before those blood clots could potentially get back to the heart and lungs. So those are the deep veins of the upper extremity. So it starts, with the internal jugular vein. With ultrasound imaging, we don't typically image the innominate. If you can see it, that's great. Some people you're just not. So it's internal jugular vein, subclavian vein, going to axillary. And then from axillary, you're entering into brachial veins, and then radial and ulnar coming down the arm. So that's really what you're going to be ultimately responsible for imaging in terms of ultrasound when looking at the deep system or the deep veins of the upper extremity of those guys. You'll also, as part of an upper extremity venous study, you'll also be looking at the superficial veins, which are the cephalic and basilic veins. So there's only two superficial veins for the upper extremities, and there's only two superficial veins really that we're concerned about for the lower extremities as well. So for the upper extremities, those two superficial veins are the cephalic and the basilic. Cephalic vein joins the subclavian vein near the distal end of the clavicle, and it runs along the lateral aspect of the arm. So it's seen along kind of the outside of the arm, connects to the subclavian and runs along the lateral aspect of the arm and goes all the way down the arm, down towards the wrist. So it is a fairly long vessel. The basilic vein can be seen now along the medial side of the arm. So this joins the axillary at the lower border of the teres major muscle, and is seen along the medial aspect of the arm, and of course you see in the medial upper arm as well as the medial forearm. So here's kind of a good schematic or diagram. So that's the cephalic vein joins the drains into the subclavian vein and runs along that lateral aspect of the arm. We do have one area that's considered a superficial vein. This is called the median cubital vein or median antecubital vein. So that's typically where most people get their bloods drawn or their IVs drawn. And that's a connection between the cephalic and the basilic veins. But that cephalic vein again joins the subclavian, of course, is all the way down the lateral aspect of the arm. So this is the upper arm, then getting into the forearm and runs all the way down towards the wrist. Same with basilic vein. So basilic vein now joins and forms the axillary vein. So axillary is made up of the basilic and brachials coming together. The basilic vein coursing along the medial aspect of the upper arm, medial aspect of that forearm, and courses all the way down towards the wrist as well. So both of these, they're superficial. They're typically going to be a little closer to the surface of the skin outside that muscular compartment. But the main thing is that these guys do not have a corresponding artery that runs alongside it. So here you can see nice diagram. Your cephalic vein coursing all down the upper arm, the lateral aspect of the upper arm, lateral aspect of the forearm. So this is all cephalic vein superficial, basilic vein superficial, going from the axillary all the way down medial side of that upper arm, medial side of the forearm, and then that median cubital vein connecting the cephalic and basilic. The reason this is part of your standard upper extremity venous protocol is because these are the vessels that most nurses or doctors are gonna draw labs from, put IVs in, just because they are superficial. So there's a lot of trauma and injury that goes into these vessels that can potentially lead to the development of thrombus formation. But we're gonna learn that next semester, some of the different factors that could potentially create thrombus formation. This was a good diagram to memorize for the superficial ones. Star that. Pretty sure that one shows
This
up.
one?
Yeah, that one shows
Just the
up.
labels that are on it now?
Yes,
Or we
yeah.
need no additional?
I have for superficial and I think I have one for deep.
Yeah, which one's the best one to look at?
For all of them.
Like, yeah, is this one probably? There's a lot going on.
A lot going on. It's not too bad. You have jugular vein,
Where is-
subclavian,
Oh, this one.
and then axillary. So just follow your deep system now. So jugular, subclavian, axillary into your brachial. And then radial and ulnar. So don't worry about interosseous veins, so radial ulnar. And superficial vein, you have your cephalic lateral and your basilic medial. On the test, it's gonna say label the deep veins or label the superficial veins. So like I have separate diagrams for the superficial and the deep.
Oh, so it's like differentiate.
Yeah, yeah. Like when I have labeled the superficial veins.
So it just gives you that, like, not a word bank or anything, it just give you the diagram.
The diagram, yeah,
Spelling count?
should. Cephalic, basilic, no,
Those ones are easy. I meant the one that I was. Then phenomenon.
innominate. Phenomena, innominate,
Was that on there?
innominate, I don't think so.
It's not gonna help. Yeah, it's not.
No, I don't think I asked you to label innominate, no.
No, I know, it shows, it has axillary labeled on the superficial and on the deep. Would that be? Cause I mean, I know it has an artery. So I wasn't sure if there was a reason it's named all that. We would give you a point to reference. You're laughing.
Yeah, it's giving you just that kind of reference point.
Okay, so but like if we were given this and it says label the superficial, just worry about the other two.
Yeah, don't worry about it, just label superficial, label superficial.
Okay,
Those are deep.
yeah.
Yeah.
Okay.
Yeah, if it says label of superficial veins in this picture, and you put in radial or ulnar or axillary, you know,
Yeah.
that's wrong. I want you to be able to recognize or know which are
Yeah, I was just
superficial and which are
That
deep.
was the only
Yeah,
one that's listed on both, so I didn't.
Yeah.
There's something weird about it. No, we're not. That's deep. I thought it was deep.
I think it might actually be labeled on there. Like, as a reference, yeah,
Already.
to give you guys reference. What do you think?
Is this like a good diagram to study? This one, or should we do the ones that you just told us?
Well, that,
Like
That
this
one,
one,
yes, yeah.
okay, so not so much this one when it says, can you name them?
I'm sorry,
Like, not so much this one when it says, can you name them? 29, yeah, that,
it'll help you.
okay. But not the one on 27, the big one?
Well, he's gonna tell us which one's which, so if they're deep.
Yes, yeah, I'm gonna tell you which ones are which, like which are deep, which are superficial. what's the only deep vein in the upper arm? Brachial, that's it.
Brachial.
Down in the forearm, what do you have for deep veins?
Ulnar.
Ulnar and radial, so radial's lateral, ulnar's medial. So there's gonna be a line pointing to like vessels, that you have to label. So if if you're in the forearm, I'm asking for the deep veins, you only have radial and ulnar. Whichever one's pointing to the lateral is gonna be that radial, whichever's pointing to the medial, ulnar. If I'm asking what are the superficial veins now in the upper extremity, you have cephalic and basilic. So whichever one is lateral is gonna be cephalic vein, whichever is medial is gonna be basilic vein. So it's really not that terribly tricky to break them apart. Spell as best as you can. I'm horrible with spelling, so I would be a hypocrite if I.
Me too.
So then, and I just want you to be able to recognize like, the order too. So like if I have one that's listed as, labeled the deep veins of the upper extremity and it's already labeled axillary, the next one should be, brachial and then radial, ulnar, or like, if something's pointing innominate, what's next? Subclavian, then axillary, and then brachial. So just becoming familiar. That sequence, like when we start imaging, you have to be able to recognize like, all right, I'm in subclavian, now I'm in axillary, now I'm in brachial, now I'm in radial, now I'm in ulnar, knowing where you are. So knowing this cold and the venous anatomy, the major pathways, is going to help you just in ultrasound.
Oh, sorry.
That's okay.
Already gone over that, but so the internal jugular and the subclavian, what type of veins are those considered?
Internal jugular, deep vein.
They're both deep veins.
Yeah, because with those, the internal jugular vein, the corresponding artery is the carotid artery.
Okay.
What was the other one you said? I'm sorry.
The subclavian.
Subclavian, yeah. So we have a subclavian artery.
Okay,
Yeah, so
they're
those are
both
all deep. Yeah, deep. IJ is deep, subclavian's deep. The innominate is deep as well, because we have an innominate artery on the right.
Two veins to an artery for deep veins, it doesn't start until after.
Yeah, after axillary, so this is when we kind of get paired. Yeah.
So if there's an artery that corresponds with it, that means it's a deep vein? Yeah.
Yes, that's how we tell it's a deep vein. Yes. Yes. That is the main characteristic of a deep vein. It has a corresponding artery with it. Yeah.
With the jugulars.
I'm sorry?
With the jugulars corresponding.
Is the
artery.
carotid artery. Yeah. So that think of it as like the highway that it's got deep veins are part of that 2-lane highway. So with the deep veins, there's got to be an artery bringing blood flow to wherever it's got to go. And then the deep vein is what's draining it out. So it's the opposite way of that highway. So deep veins are part of that 2-lane highway of the arterial system. Whereas superficial veins, they're just kind of doing their own thing. They're draining. Well, they're draining the superficial tissues. So they're part of the drainage system from like the superficial tissues.
Spell innominate.
Innominate.
That,
INNOMINATE.
so it's missing an N.
Am I missing an N?
No. Oh, I didn't realize it was one other one, sorry.
Is it on? Do I have a good one?
I don't think it's labeled on any of them.
No,
Yeah.
why not? No. Nope. 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 Right there. Hello. Yeah. Supervision to. There's a nominate. INNOMINATE.
chapter 4 workbook will still be next week, right? Cause I know we need the workbook.
Yeah, still do, yeah, so it'll be part of that. Yeah. I think chapter 4 is all the anatomy. Do that after we finished, alright. So deep veins for the legs now, so IVC is considered a deep vein, its corresponding arteries are aorta. So it is a deep vein. So just talking about the coming together or the branching of the IVC branches into the common iliacs. Those common iliacs then branch into external iliac vein and the internal iliac vein. So the internal iliac vein, we don't image typically on ultrasound. That drains our pelvic organs, the pelvic floor. The deep veins are that, I'm sorry, so the external iliac vein is what drains the lower extremities, the legs, so we focus on that external iliac vein. The deep veins are the major route of venous drainage for the legs. Again, deep veins are always accompanied by an artery of that same name. So when we're talking about the lower extremities, some vascular labs will start imaging the lower extremity veins starting at the common femoral. Some places will start at that external iliac vein. So that line is going to be your inguinal ligament. Inguinal ligament. So proximal to that inguinal ligament or above the level of that inguinal ligament is going to be your external iliac vein. Once we cross below the level of that inguinal ligament, it becomes common femoral vein. Above it, external iliac vein. Below it is common femoral vein. I'm just going to abbreviate CFV, common femoral vein. So again, common femoral vein has a corresponding artery, common femoral artery. That common femoral vein will then split into the superficial femoral vein and then the deep femoral vein. So there are some other names for those two vessels. So this is probably the biggest change that they've done in recent years is they've dropped the word superficial from that vein and just called it the femoral vein. Because there were a lot of issues in the hospital where patients would be positive for DVT in the superficial femoral vein. And depending on the doctor reading that report, they go, oh, superficial femoral vein. All right, never mind. We don't have to treat this. That's a big, huge mistake because that is a fairly large vessel that's, proximal in the thigh, and that's a big DVT. That's a big blood clot if that vein is thrombosed. So now, in order to just err on the side of caution, we refer to this superficial femoral vein as just the femoral vein. So common femoral vein splits into femoral vein and then deep femoral vein. That deep femoral vein you might also see referred to or called the profunda femoris, the profunda vein. So CFV branches into the the femoral vein and then deep femoral vein. So I'm just going to kind of put the two branches there. Say DFV, deep femoral vein, and then just FV femoral vein. This is in the proximal thigh, so this is still kind of in the groin. That femoral vein is the one that we really image on ultrasound, courses through the thigh. And then once we get to the behind the patient's knee, that's when that deep femoral vein becomes the popliteal vein. So popliteal vein is a continuation of the femoral vein through the abductor canal. So it's posterior to that popliteal artery. So once we get behind the knee, and what's called is the popliteal fossa, becomes popliteal vein. Abbreviated pop vein. So similar to arteries, those veins are going to also bifurcate or split into the anterior tibial veins and then the posterior tibial or the tibial peroneal trunk. And that tibial peroneal trunk will then split into the posterior tibial veins and peroneal veins. ATA. So popliteal vein courses behind the knee. Once we get into the calf, that popliteal vein splits into the anterior tibial vein. So I just kind of wrote here ATA is the most lateral. So again, anatomical orientation, patients kind of like, like that. So the most lateral is going to be your anterior tibial veins. Most medial, if the foot is turned out, is going to be your posterior tibial veins. And then the peroneal veins are in between the two. So same like the arteries. Anterior tibial, most lateral. Posterior tibial are going to be the most medial. So I kind of drew posterior tibial, these guys being the most medial, these guys the most lateral, it's the right leg. Peroneal veins are in between. Once you get down below the popliteal, these veins are now paired. So you're typically going to see two veins in one artery. So kind of similar to the upper extremity, move it, where it became paired at the brachial level. Now we're getting paired at below the knee. So below the popliteal, the anterior tibial veins, you'll see two veins in one artery. Posterior tibial veins, you'll see two veins in one artery. Peroneal veins, you'll see two veins in one artery. These are paired. About a quarter of the population will have a duplicated popliteal vein, so it might look like two veins in one artery. So it'll look like it could potentially be paired as well. So there are anatomical variations that do exist still.
These are all in the.
Yeah, these are all in the calf. So here. So we have our knee popliteal vein. So this is behind the patient's knee. We get branching now into anterior tibial veins, and then this is that tibial peroneal trunk. That tibial peroneal trunk then splits into your peroneal veins and posterior tibial veins. Yep. Yes. This is higher up now, so we can kind of draw, that inguinal ligament here. So above that inguinal ligament, external iliac vein, below it, we have our common femoral vein. So this one we're gonna get into in a moment. This is one of our superficial veins, but that common femoral vein splits into your superficial femoral vein. So we like to ditch that superficial term, just call it the femoral vein. And then the deep femoral vein. So we have femoral vein and deep femoral vein. Deep femoral vein continues down the thigh, get behind the knee, becomes a popliteal vein. And then once we, after the popliteal vein, continuing down the leg, we then branch into anterior tibial, posterior tibial, and peroneal veins.
For like an exam, when we have to label those, will there be the inguinal ligament, or how do you call that?
Yes.
You'll put that on.
Yes,
Okay.
100%. Yep. 100%. Yeah, it'll be labeled inguinal ligament. It'll kind of, you'll see like a line and an arrow pointing to it. It'll say inguinal ligament on it. And if it's above it, external iliac vein. If it's below it, common femoral vein. Same thing with the arteries as well. External iliac artery, common femoral artery below it. So again, just kind of recap, deep veins all have an artery associated with them. Deep veins for the legs, external iliac, common femoral vein. We have the deep femoral vein, which we see a small segment of, but we don't typically image. Continuing down the leg, femoral vein, popliteal vein, anterior tibial, posterior tibial, peroneal. How many we got? 1, 2, 3, 4, 5, 6, 7, 8.
I'm sorry, is this a long sapling with that?
So this one's actually a superficial vein. So we're gonna go over that in a moment. Yeah. So these are, yeah, so that long saphenous is a superficial one. So there are a couple more deep veins that do exist within the lower extremities. So a lot of the venous protocols don't necessarily image these, like dedicate image to these. But as a good sonographer, it's a good habit for you to actually check these veins. It's quite easy for you to, do a quick glance and check. Particularly soleal vein, because this is the most common site for the origin of venous thrombosis. So these veins are very small. They exist in the calf. So if you kind of just look at the name of this vein, gastrocnemius vein, gets its name from the gastrocnemius muscle or calf muscle. The soleal vein actually gets its name from the soleal muscle, which is a muscle of the calf as well, which sits posterior or deeper to that gastrocnemius muscle. So with these guys, the gastrocnemius vein joins into the popliteal vein, so you'll see it as a little branch or tributary connecting into that popliteal vein. The soleal vein will drain into either the posterior tibial or peroneal. I've seen them go into both, probably 50-50 split, but it'll connect eventually into either one of those sets of veins, either the posterior tibial or peroneal veins. So this exists a little bit further down the calf, so it's kind of like mid calf to distal calf. Whereas this we can see, really at the top of the calf connecting into that popliteal vein. It courses through the entire calf, but it's best visualized in that popliteal fossa. So next semester, when we get into imaging this, we'll go over this a little more in detail. But just realize that these are considered deep veins as well. So I want you to recognize that. So these will also have small little corresponding arteries with them. So this was showing a sagittal picture of the popliteal vein with that gastrocnemius vein at its origin, or where it connects into that popliteal vein. So this would drain, so the feet are down this way, so this vein is draining in this direction into that popliteal vein. These are some ultrasound images for the soleal veins within the soleus muscle. So this is more of a transverse view. So you have little vein, and a small little artery that's with it. So these are very, very small.
So is that normal? With that,
To be small like that.
or just like the look of it?
Yeah, they're teeny. A lot of people, you won't even see the soleal veins. unless it's positive, when it becomes thrombosed, it becomes much larger and dilated and filled with clot. So it makes it a lot easier to see. And when you actually see how small these really are on people, like, I mean, this is like millimeters in diameter, and it's probably zoomed in. All right, so deep veins. External iliac, common femoral vein, deep femoral vein, popliteal, anterior tibial, peroneal, posterior tibial. Gastrocnemius and soleal veins are also considered deep. And then we have two superficial veins in the legs. So similar to the arms where we had cephalic and basilic, in the legs we have the GSV, the great saphenous vein, and then the small saphenous vein. You might also see the great saphenous vein referred to as the long saphenous. You might see that as another, I guess, another name for that vessel. So this GSV, the great saphenous vein, is the longest vein in the body. So it runs all the way from the groin at that where it joins into the common femoral vein, runs all the way down the medial aspect of the leg. So it's the inner part of the leg, inner part of the thigh, and goes all the way down past the anterior to the medial malleolus and onto the foot. So depending, on the size of the person, you can imagine how long this vein really is. It's a major collateral route. People can live without the GSV, so this vein is actually commonly used for harvest. So they'll actually go in, remove this patient's vein and use it for bypass surgery. So they could take a portion of that vein, use it for bypass for the heart. Say a patient's got bad coronary arteries in their heart. They need to go, and you hear people go, I had triple bypass, quadruple bypass. They would like to take a segment of that vein, use that vein to get past blockages in the arteries of the heart. So they'll kind of go use the segment of that vein to get blood flow around areas that are blocked in the heart, to bring blood flow to the areas that need it. They can also use that vein to bypass blockages in the arteries of the legs. That's another common use. They'll actually could potentially remove that vessel, turn it upside down, connect it to the artery, and allow blood flow to get down the leg in the artery. So they can use it for that. So it's often used in bypass surgery. They'll tie off the top portion, they'll tie off the bottom portion, and then actually strip it or remove it out. Depends how much they need. Yeah, they typically remove the whole thing.
Pull it out. Of like a hole in your leg. Pull it out.
Yeah,
Ah,
well,
it's like
yeah.
your top part, but like your bottom part.
It depends what they need to bypass. If it's for the heart, they might use some of the smaller segments because you want it to kind of match up. Because those arteries in the heart are pretty small. But if you're using it for the legs, particularly if you want to connect it to a larger common femoral artery, they would use the larger end of that vein to connect to that. But yeah, we'll also think too, patients who have really bad varicose veins, if I don't know if anyone.
Oh, that's what, a couple of my friends have had that procedure.
Yeah, so they'll actually ligate or thrombose. There's a lot of different procedures that are out now. They can use radio frequencies or lasers to actually cauterize and like shrivel up that vein to help reduce or minimize varicose veins. Because in varicose veins now, blood flow is kind of flowing in the wrong direction. It's flowing, instead of going from the superficial veins into those deep veins, it's going from the deep system back into the superficial veins. Causes this GSV to become very large, dilated. This then bleeds into a lot of the smaller superficial veins and creates those very large varicose veins. So by cutting off, that GSV and preventing that blood flow from going back into those smaller veins, you can alleviate those varicose veins. Oh, the perforators?
Yeah.
So yeah, it goes from the deep system through those perforators into the GSV. And then from the GSV, it goes in, branches out into the smaller collaterals, the superficial veins that are very close to the surface. Yeah. Tiny, well, they become very large and engorged, yeah. So they become those larger varicose veins that you see. Yeah, they're different from the perforators. Those are right on the surface of the skin, like. So it starts at those and drains into the GSV, and then from the GSV into the perforators. And then from the perforators into the deep system. So the other vein that we have in the other superficial vein is the small saphenous vein. So you might, some of the older terminology is this lesser saphenous vein. So we have great saphenous, lesser saphenous, or small saphenous. This one empties directly into the popliteal. So this is commonly referred to as a stocking seam vein, because it runs directly along the middle part of the back of the calf. So straight up and down along the middle of the back of the calf. So I guess there were old stockings, old women's stockings, so think of like the little old grandmas that had the little stockings that came up. There was a seam that ran along like the back of that stocking, like right in the middle of the calf. So if you're coming posterior, that stocking, the small saphenous vein runs directly along the middle of the back of the calf, the posterior calf, and connects right into the popliteal, so behind the knee. So this is showing that small saphenous vein connecting into the popliteal. So you guys just have to be careful eventually when we start doing venous imaging, because the gastrocnemius vein looks very, very similar to that. And when we start imaging, you'll actually, when we come to image the popliteal, you'll be able to see small saphenous vein, gastrocnemius vein, almost at the same level. But one will have that artery with it and the other one will not. It'll just be the vein by itself. So superficial veins, GSV, great saphenous vein, longest vein in the body, small saphenous vein, also referred to as that stocking seam, empties directly into that popliteal. Also, this is just showing that GSV, where it connects all the way into that common femoral vein up at the groin, how it extends basically the entire length of the leg. And this is a posterior view looking back at the calf, and a small saphenous vein connecting into that popliteal. And runs along that posterior calf. This was a good one for the legs. Star this one. You got your inguinal ligament right there. So your inguinal ligament. So above it, external iliac. Below it, common femoral vein.
So is the common femoral vein, that's considered the thigh? Or is that considered the groin?
You're up in the groin. Yes.
Yeah.
Yeah, you're up in the groin. Yeah, what you're. Femoral, deep femoral vein. Your GSV is going to be medial. Yeah. Yeah, it's sharing on here like it should be on. Yeah. That's just to show my pretty face. So again, just become familiar with your vessels. I know it seems like a lot now, but really just once you get a hold on the anatomy, it just makes vascular so much easier. Once you understand your basic anatomy and the vessels that we're imaging. So these are just some more diagrams to just help you. Common femoral branches into femoral vein and then deep femoral vein. The femoral vein continues down the thigh, becomes popliteal. Popliteal then splits into your anterior tibial. And then the tibial peroneal trunk. Tibial peroneal trunk becomes posterior tibial and peroneal. This was just showing some anatomical variants. So some people can have duplicated venous systems for the femoral vein, as well as the popliteal vein. Let's just showing a duplicated popliteal vein. A duplicated femoral vein. Where they actually have two femoral veins. This one has a common femoral vein where there's no separation between the deep and the superficial. So here's that inguinal ligament that you can see in that picture. So for below it, it's got to be common femoral vein. The common femoral vein then splits into femoral vein and then the deep femoral. That femoral vein continues down, becomes popliteal. That popliteal then branches into your anterior tibial. And then, yeah, tibial peroneal trunk is the red one. And then most medial, it's going to be posterior tibial. In between is going to be so peroneal in between, and then anterior tibial most lateral. The 3 is supposed to be tibial peroneal trunk, but like the arrow on this picture wasn't good, so like we kind of drew it in. It's actually that common part before it actually splits is your tibial peroneal trunk. So this was just pointing a little too low, so that's why we drew that red arrow. That was a big sound. So again, this is just kind of a recap of some of the stuff we talked about before. So this is arterial wall now, microscopic anatomy of arterial wall. So that inner layer, that tunica intima, is the innermost layer. Oh, you need me to go back? Yeah, no worries.
Thank you.
So that tunica intima is that innermost layer. It's comprised of smooth endothelial cells and connective tissue. The middle layer is the tunica media. This is the thickest layer when we're talking about the arteries. It's comprised of smooth muscle and connective tissue. So this is really what helps to give the artery its stiffness and ability to handle those increased pressures. And then the outer layer is the tunica adventitia. Since the outer layer is made of elastic and collagen fibers connective tissue, and also has a few smooth muscle fibers as well. An important thing for you guys to also realize is that vessels are living tissue. So just like any living tissue, any organ, it also needs blood supply in order to survive and stay alive. And what supplies blood flow to our blood vessels is something called the vasovasorum or vasovasorum. So this is a network of small blood vessels that supply the vessel walls. So this is what actually brings blood flow or nutrients to the actual vessels themselves, this vasovasorum. So this is again just showing the differences between the arteries and veins. So this is the arterial wall segments, the venous wall segments. So you can just appreciate how much thicker those arterial walls are compared to the veins. Does anyone remember with was it transmural pressure? If a vein has high transmural pressure, is it going to be round or is it going to be flat? Round, good. So high transmural pressure will have a nice round vein. So high transmural pressure, think of it, the pressure inside that vein is pushing out. That transmural pressure is pushing outwards and creating that nice round shape. So that has high transmural pressure. Low transmural pressure for a vein, you're gonna get those flat, like dumbbell shaped looking ones, or the flabby veins that are not nice round circles. For venous anatomy, so it's very similar to arterial. So same names in terms of the vessel layers. They're just thinner, you know, so there's more fibrous tissue, less of that smooth muscle and elastic tissue than an artery. So with this, that tunica adventitia, the outermost layer in the vein is the thickest. And this is the elastic collagenous fibers. So it allows veins to stretch, gives veins a good deal of stretch to them. So that's why veins can tend to become very enlarged and very dilated. You see very large varicose veins on some people because the veins do have a high degree of stretch to them, but they're not stiff and rigid like the arteries are. Again, veins are also fed by that vasa vasorum layer, that small network of small blood vessels. This is just kind of showing the vessel layer walls going from, this is the outside and then this is the inside, the intimal layer, the inner layer. That vasa vasorum they lie along the outside or the outer layer and supply blood flow to that adventitial layer, that outer layer, the vasa vasorum, and that nutrients kind of seeps inward. That was it. So we did blood pressure measurements. So when we get into lab, we're going to be doing the full PVR SLP today. All the cuffing. So this was just kind of a nice diagram showing where to find that dorsalis pedis artery, that location. So if you have the patient flex their toe, you'll see this flexor tendon off the great toe, and it lies lateral to that flexor tendon. This was kind of a cadaver showing that flexor tendon, and then that dorsalis pedis artery forcing on the top of the foot. I'll help get you a little appreciation. And then being able to palpate it. And then here's that posterior tibial artery that we go. So here's our medial malleolus, that inner ankle, and the posterior tibial artery coursing posterior to that medial malleolus. So we practiced cuffing a little bit last week. We're going to do all the cuffs now. So again, selecting the proper cuff size. So the width should be about 20% greater than the limb diameter, or 40% of the limb circumference. We're going to wrap the cuff snugly and fit. So you want to be able to slip about only one finger into that proximal end of the cuff. You wanna make sure the tubes are not interfering, with any of the insinuation sites where we're listening. So particularly that comes into with the ankle cuffs, try and raise it up a little bit to give you some room to be able to, listen for that, posterior tibial pulse. These are gonna be our cuff size, so in general, we have 10 centimeter for the arm and ankle, and then 12 centimeter for that high thigh, low thigh, and calf. So when you're finished, you wanna try and put them away in a nice orderly fashion, so it's easier for you to find the cuffs, so that's what I was doing back there, making my little pockets or cuffs. So each bundle should be for one side of the body, so you're gonna have a left side of the body and a right side of the body. This is just showing the cuff placements. So we did last week brachial and ankle, but now we're also gonna be placing a calf cuff, a low thigh, and a high thigh cuff. So this is a 4 cuff method, referring to the 4 cuffs of the lower extremity. We do have a metatarsal cuff that we're gonna be placing to get pulse volume recordings for our metatarsals. The machine does come with a little toe cuff if you have to get toe pressures. So if you're ever doing an upper extremity PVR, this would be the placement for upper extremity. So we're gonna do that a little late, actually, probably during the summer, we'll do cuff placement for upper extremity. But if you had to do an upper extremity PVR, we do a brachial, upper forearm, lower forearm, as well as a digit. So it's just showing good cuff placement. So arterial cuff placement for low extremity segmental pressure. So when we're actually getting the pressures, we remove that metatarsal cuff. But we'll go over that in lab. Just for your reference. All right, let's